Hi, everyone. Welcome back. It's time for our second panel, Opportunities for Equitable Digital Health Transformation Beyond COVID-19 Through Policy and Healthcare Changes. I'm going to turn it over to our moderator, Dr. Michael Penn, who is the founder and managing director of Health Equity Ventures and longtime friend and collaborator to us at UCSF Solve Health Tech. Thank you, Michael.
Thank you, Urmimala, and welcome everyone. And I am so fired up and so excited. We have been launched into a fantastic discussion by Reed and his fellow panelists. And I would like to introduce my esteemed panelists today, starting with Dr. Lisa Fitzpatrick, founder and CEO of Grapevine Health, Pooja Mittal, medical director of Population Health Equity at HealthNet, Dr. Edmondo Robinson, Senior Vice President and Chief Digital Innovation Officer at Moffitt Cancer Center. And for the next few minutes, we will be kicked off by Dr. Micky Tripathi, National Coordinator for Health IT, Department of Health and Human Services. Micky, would love to hear you set the stage and the context for our discussion. Thank you.
Great. Thank you, Michael. Can you hear me?
Yes.
I always want to make sure. Okay, great. Thank you. Thank you so much for the invitation, and good morning and good afternoon to everyone. Just really delighted to be here, and especially with this like great colleagues here on the panel. So just thought, give just a few comments and thoughts on ONC and what we're doing in related to healthcare equity and social determinants of health, and then really look forward to the panel discussion. In terms of ONC in general, as we think about, what role do we play within healthcare systems as, at large, we have, a few things that I think, help to set up and help to guide the direction of health information technology and interoperability, all of which, in general, has huge importance to equity considerations. And then there's specific things also that have, even greater focus and greater, greater specificity as it regards, directly addressing equity-based issues. So, just to highlight a few of the general things that ONC does, and then I'll talk a little bit about, how we're thinking about health equity in particular in our programs, is, we provide sort of guardrails and standardization around data and technology approaches to assist industry innovation so that it can provide, sort of a playing field and in a level competitive playing field, which is what, we're always trying to do, which is to say that we want very healthy, innovative environment for private sector companies, nonprofits, and others to be able to do all of the innovative things that we hope that they're going to be doing. But part of that is being able to set up certain guardrails, certain sort of directional feedback that helps to directionally guide the market toward things that ensure that competitive playing field. Most recently, I think what the initiatives that we have as you think about information blocking, FHIR-based APIs, things like that, are really focused about moving the industry toward what we might think of as sort of a platform-based approach from a technology and from a business perspective, which is to say things, tools, approaches that enable apps, individual apps. Everyone's familiar with the apps that you're able to download on your Android or your iOS device if you have a smartphone, and being able to enable that kind of user experience and individual preference and the ability to be able to do things more and more in your control. Of course, we recognize that not everyone has access to those kinds of technologies, and that's certainly a part of how we want to think about these issues going forward. The second thing that we do is, we raise the floor on expectations for data sharing and baseline technical capabilities. Again, that's a part of that competitive playing field, the level competitive playing field, which is to say that, we have expectations now instantiated in the information blocking rule that require that organizations start to think about sharing information, not as something that is, permission-based per se, or waiting for someone to give permission for it, in terms of yourself having it be, sort of permitted and only if asked, and flipping that to say there's an obligation to share information with individuals, with other providers, with other authorized parties on behalf of the patient to ensure better access to care for everyone. So that's that's an important part of what we do as well, which is raise that floor and expectations and have that be a rising floor of what all healthcare parties are required to share. The third thing that we do, and we do a lot of this, and this is the C in our national coordinator title, is convening industry and federal stakeholders to identify and advance opportunities for collaboration. There's a lot that we do. We always have the regulatory stick, but that's a pretty blunt and crude instrument. I think most of us would agree. And so we spend a lot of time doing the sort of the collaboration among parties to help identify industry collaborations, and the federal partners are an important part of that as well, because the federal government has all sorts of different agencies, I think, as you know, who don't always sort of row in the same direction, and that's really confusing and can be things that don't contribute to the industry's ability to be able to move forward. So let's say we're spending a lot of time working with the federal partners to say, how do we keep ourselves aligned so that industry can move forward in the best way possible? Last point I'll make is, as we think about health equity in particular, and sort of a concept that we think of as health equity by design, we kind of break it up into 4 categories, and I can certainly talk more about this in the panel discussion. But we break it out into standards and data, infrastructure, policy, and implementation. And at ONC, we have programs in each of those areas, and we're spending a lot of time now thinking about how does health equity play in every one of those aspects, so that we're thinking about it as a design consideration across the board, so that sets us up to be in a position where it's not an afterthought, it's something that is a part of the design in everything we do. So thank you very much, and look forward to the conversation.
Thank you, Micky. So let me just quickly review our session objectives, and I loved the point that you made about raising expectations. So we're going to raise the expectations in our session today. We are going to reimagine digital health in the context of improving health for all populations. How do we change the fabric of our organizations and our daily work? And we're going to dig as deeply as possible into specific examples, approaches for payers, policymakers, healthcare organizations, right? How do we align internal priorities and objectives for health equity? So I'm going to start us off in a visionary state. And so I'm going to ask each panelist to tell us a story about the first thing that they would do as it relates to advancing digital health equity if they knew they couldn't fail, right? This is an unconstrained practice that I try to step into frequently, right? What would you do if you knew you couldn't fail? Dr. Lisa, can you kick us off?
Yes, good morning, and thank you so much for having me. I love these questions because I can say whatever I want, and it makes sense. What I would do first is I would ensure everyone who has a smartphone knows exactly how to use it. What we're seeing is there's a conversation about the digital divide and how people on Medicaid or from underserved and under-resourced communities don't have access to the health innovations that are being developed right now. But my position is we need to think about the tech they're using and provide the support they need to know how to use those devices. And the second thing I would do is ensure parity and access to remote monitoring tools, because I think we're missing so many opportunities to improve chronic health conditions just by allowing or enabling access to very simple things like pulse oximeters and scales, cardiovascular devices, and so on. So that's what I would do. It sounds really exciting.
I love it. I love it. All right, unconstrained thinking. Pooja, can you go next?
Sure. Good morning, everyone. Great to be here with you all today. That's a big wish list that you just put out there. But the thing that comes to mind for me is starting with something like this, an event where we can all be in the same place and talking about how we can get on the same page about what we need. And I think doing that at a bigger level where we would have really every type of stakeholder in the room and have an ability to make decisions that would move forward towards better digital health equity for all. And I think that would mean that we would need our community members in the room too, to be able to weigh in on what would work for them and how we could get there together. So, I would put in a plug for having some of the people that we're trying to serve also as part of these conversations, really in an ideal world.
I love it. Inclusiveness. Edmondo.
Yeah, so yes, and because I like both of the first answers. And Lisa talked about, this digital divide, this concept of the digital divide, right? And so it's something I worry about every day in terms of how do we reach the breadth of the population of our patient, of all of our communities. And so, if I couldn't fail, I would make high-speed Wi-Fi broadband available to absolutely everyone. Right now, I'm not saying that's the end-all be-all of, because there's a lot. We talked earlier in the last panel about digital literacy and numeracy. There's all these other pieces that you'd have to, but I worry a lot about infrastructure, and I worry about whether or not we have the things in place to actually take advantage of all these innovative approaches to improving health. And so I actually want to build the infrastructure. We talk about infrastructure in the US, right? We talk about the roads and the bridges and all of that. I'm thinking about the digital infrastructure and making sure that we all have access to that in a way that's equitable.
I love it. Well, infrastructure, Micky, this is your domain. Do you want to talk about your vision in an unconstrained fashion? And we do have a lot of compassion for you. You do work in government, so you're dealing with constraints that many of us don't have to.
I was going to say,
so we want you to know that we got your back, and we're here to support you. So please share your vision.
Excellent, thanks. Yeah, I've only been a federal employee for 3 months, but I have quickly learned that things I say get interpreted as policy, so I need to be careful here. So Micky Tripathi, speaking personally, if I could, wave my wand, I guess there'd actually be two things. One of them is a little bit technical and wonky. One of them is more broad-based. I think, one is I would like to sweep away the way that we pay for healthcare and have everything be based on value-based purchasing, which is to say that providers are paid to keep people healthy. Regardless of their circumstance, regardless of where they are, they should be paid to keep people healthy. I know there's a lot of complexity with that, and we want to have that, sort of the appropriate risk adjustments and all of that. But I feel like that's just something that we need to be able to move ourselves toward, because every time I've seen those kinds of sort of payment models in place, you immediately see people's minds shift about how do I get the right data, how do I make the appropriate decisions, how do I engage the patient in a way so that the patient and the provider are working much more closely together than a typical model. The second thing I would do, and again, this is a little bit wonky, is I would sweep away the way that we do medical records today and actually have personal health record data banks, so that each of us, really has all of our own data in like a bank, and then you give access to providers. And that'll help to set up, kind of some of the things that I think that Lisa was talking about, which is then individuals have the ability to have, through technologies, whatever it is, smartphones, whatever, to be able to access their own information and make that information available to others. But then we don't worry about, is the information getting to the right place? Do we have privacy issues about sharing? Because the individual is then in control of everything. But that would be a real big lift.
Thank you, Micky. It's interesting as an investor. I mean, one of the reasons that I started Health Equity Ventures was really based on this notion of bringing innovations to the communities that need it, the most vulnerable, first, not last or never, right? It's a complete mind shift, right? What does the world look like if we think about taking our best innovations and bringing them to the most vulnerable first, right? That's the orientation that I think about. I want to shift, right? So we've kind of set a beautiful vision. For those of us who have been in complex organizations, trying to advance change. We know that there are institutional antibodies that form very quickly and in a robust fashion, right, to sequester, right, any change from the status quo. And so I want to spend some time thinking about how do we anticipate, right, kind of this antibody response? What things do we need to prepare for and anticipate, right, as we're building this vision? Pooja, I'd love for you to start us off, perhaps. I think you have a very interesting perspective at HealthNet, and I'm sure you've seen some of these antibodies and perhaps have had to figure out ways to evade. So please share.
Yeah, being at a health plan, I came from the safety net prior to working at a health plan, and it's been a really interesting shift for me and really positive in a lot of ways in that my leadership is really focused on health equity. And I think what we're trying to do is really build that into the way that we do our work. And it's hard to do that in an environment where things are pretty matrixed and siloed in an organization. And so certainly one big issue that comes up is that different departments look for different requirements for their health vendors. And there's often a lot of overlap between what people are looking for, and they don't always check with each other as to what might be like the one or two unifying things that could sort of help everything. And then there's also a lot of complexity in bringing on a digital vendor. I think from the lift required from contracting and privacy and that aspect of it, but also it's really how do you find a vendor that has put digital health equity at the forefront of what they're doing instead of as an afterthought, because that really influences our ability to be able to bring them in Medicaid first, right? And when I enter into a relationship with a vendor, when we're vetting a vendor, I prefer to have a Medicaid first solution, because really that's where I know I'm going to get the biggest bang for my buck, right? That's the population that I'd really like to support. When we look at comparing that to a commercial population, the commercial population often has a lot of digital tech available to them, and they may not even be as interested in a solution the way that a Medicaid population may be, because they're seeing much less in this world of like Apple Watches and all of the other access that's available. And so when I enter into a relationship, I really look for a Medicaid first vendor, and that's not always easy to find. And many of the vendors that we work with are commercial first, and they come in and say, we can do Medicaid though, we'll do it. And that translation in terms of how long it takes for them to really grasp, especially in California, the regulatory requirements around language and access is really a big lift. And so, we know that the state is really diligent about protecting Medi-Cal members, and that's important, but it also makes it really difficult for us to get sort of a new vendor that hasn't been vetted to get on board with Medi-Cal. And that really delays our getting the technology to our Medi-Cal members. And, I think there's also, you brought up, Edmondo, the digital divide. That's a huge issue. There are certain vendors that are much more conscientious about not necessarily needing access to broadband to be able to really access the app in a legitimate way, being able to download things when you're on Wi-Fi and then being able to access it later. Sort of all of these things that make it really much more accessible to a population that doesn't have access to broadband all the time, right? And then I think the language requirements are also complex, in that we need a specific threshold language requirement, and not all vendors can meet that requirement. I think Consejo Sano is a great example of a vendor that makes that very easy for us, because they've thought about that and they've consistently put that population first.
Thank you. Edmondo, I'm wondering, this idea of Medicaid first, right? So it's kind of a philosophy, right? Do we need to promote more companies that begin with that end in mind? Or are there opportunities to retrofit, create APIs, if you will, right, to connect other innovations that perhaps weren't designed for the populations that we're talking about? What are your thoughts?
Well, I mean, the answer is yes and yes. I mean, you can go both ways, but I think the points being raised about, you know, in some circles, it's kind of this idea of reverse innovation, which I think is weird, but whatever. That's kind of what it's called, where you go to the under-resourced area first and innovate there, and then you scale it out to the higher resourced area, and you actually can be more effective that way. I think that's an absolutely legitimate approach to innovating in digital. And so, you know, is it, you know, maybe the question is it sexy enough for folks like you who are going to invest? Now, not you specifically, because we know what you do, but, you know, for folks who are actually going to invest in this development, because some of these, you know, let's talk AI and ML algorithms, right? The amount of data you need to train these models, the investments you need upfront to truly drive in any one particular subset of what you're trying to develop, you actually need pretty significant investment sometimes on some things that you're building. And so can we get the investors on board with this concept that we're actually going to innovate in our least resourced populations? And that's actually going to raise the boat, essentially, kind of, you know, rising tide raises all boats. That's actually going to drive value, not just for health outcomes, but actually for the investors themselves, faster and further than what would otherwise be your approach, you know, kind of focusing on that commercial side.
Yeah, no, I couldn't agree more. And I think part of the way we think about this at Health Equity Ventures is we have to grow together. We have to figure out how to communicate and partner with other investors to share insights, right? To share the opportunities that we see that they may not. And in fact, no matter how big a fund Health Equity Ventures becomes, we need partners, right? We need government partners, we need philanthropic partners, we need co-investing partners in the venture community, et cetera. Micky, what are your thoughts about things to anticipate? How do we bring together different sectors, because we all need each other to get this done?
Yeah, I mean, I think it's important. I think, you know, to think about this, the bringing together of different sectors, because it's really easy to figure out technologies, but really hard to make them stick across all different communities. If you're thinking about, you know, thinking about putting something into place and having it actually be adopted and used. And to the points raised earlier, you know, just because something works in a, you know, in a relatively well-resourced digital environment doesn't mean, people often make the assumption that that's going to work in, you know, communities that of marginalized or underserved or minoritized communities. And that's, you know, that may or may not be the case. And every one of those communities is different as well. I was just reflecting on Edmondo's comments. I, you know, been involved in some work in, you know, before I joined the federal government, where we were looking at remote diagnostics technologies for use in developing countries with no internet infrastructure or Wi-Fi infrastructure in the field. And so working on how would you have those technologies be enabled so that you could actually do testing, let's say in remote environments, be able to collect that data electronically in some way and then have it sync up. And presents a different technology problem than an assumption of I am connected 24/7 with a, you know, with an advanced iPhone. That quickly turned into a conversation of, there are many pockets of the US where that technology, you know, that technology does not just live in Africa or South Asia or those environments that, you know, that happen to be the funders for that. There are many places where you could think about, I agree with you, reverse innovation is a really weird way to frame that, but, you know, there was a thought of, you know, why aren't we thinking about those technologies being used in the US to, you know, make sure that everyone is somewhere on the glide path to be able to take advantage of these technologies. I saw in the Q&A also, there was a really good question, which is, why do we assume that everyone wants to take advantage of these digital health technologies? Because they may not. And I think that's a fair enough point. And I guess what I always come back to is that everyone should have equal access to those things. And then for those who choose not to, that's fair enough, but, you know, but they should have equal access. And we also should make sure that even if an individual doesn't want to have that access, that their providers have equal access to all of those digital tools, so that those providers who are safety net providers or serving communities that aren't as well resourced, that they aren't, living, experiencing that digital divide in that healthcare infrastructure as well. They should have access to all of the tools on behalf of their patients.
That's an excellent point, right? That this idea of equal access is relevant to the entire ecosystem, right? So not just the patient perspective. So Lisa, what should we be aware of or thinking about as it relates to the front line, right? The lived experience. I see so much disconnect and fear of the unknown, and almost, a lack of willingness to sit in someone else's shoes to actually be with their pain. And you've very intentionally spent the last several years doing exactly that. So can you illuminate for us how do we transmit some of that lived experience, right, into these organizations, into our mindsets? You're on mute.
Thank you for the question. I think the first question we have to ask ourselves, whether we're sitting in the C-suite, you're running a venture fund, providing clinical care, wherever we are, we have to ask ourselves if we want to know the answer. I've actually had a healthcare leader say to me, do we really want to get that information from the community? Because we'd have to do something about it. And this was a conversation that was off the cuff, and we were really talking openly about how these disparities we're facing during the pandemic have been here for decades, and we're acting as if they're new. So what's really going on? And a lot of these solutions, listening to the community, we say these things all the time. We talk about, we need to address social determinants of health, and we have all of these buzzwords. So what's really going on? And that's when he said that to me. And I realized that we have to make an internal assessment, organizationally and personally, about whether or not we're willing to do what's necessary. So for some people, that is going out into the community. Some of us are comfortable doing that. Others are not. But if you're a C-suite leader, or you're someone who commands and influences policy, the allocation of resources, I think we all have a responsibility to invite that voice in. And I think someone said this earlier, and it sounds trite, it sounds simplistic, but it's not happening. And I also think we find it easy to reach out to our community service organizations or our advocacy organizations. They're our friends. We talk to them all the time. We speak the same language, and they're speaking on behalf of the community. So when I say we need to speak to the community and listen to what they're saying, I'm not talking about the filtered version through our partners, our community service partners, the leaders of these organizations. I'm talking about talking directly to the patient, talking directly to the enrollee or the member, whatever the term is for your health insurance plans. Finding a way to get that information directly to say, what do you think is wrong with the system? Do you want access to a digital health tool? How do you like the experience you had when you saw your doctor last time? Those are the data points we are missing, but I think we are missing them willfully because we don't want to be held accountable for this. So when I'm in the community talking to people, what I hear over and over again is that these challenges we're facing are being driven by distrust, low health literacy, or not really understanding. We haven't done our part to help people understand how to interact with the healthcare system, or even with these innovations that are not accessible to them. But also trauma is something we don't talk about. And so the disconnect is because we're not listening, we don't know how to build these tools for people. And so I just want to encourage everyone who's listening to think personally and organizationally what you can do to take the extra step. And it might sound scary. If it sounds scary, just call me. I'll give you some helpful hints. But we've all got to do our part to really listen with 2 ears and find out what the solutions are. Because if we ask them, they'll tell us.
Thank you, Lisa. I really want to underscore this point, because what we're talking about is discomfort. We're talking about sitting with inequity, right? That in some ways, intentionally or unintentionally, we are all somehow complicit, right, in their persistence. And I think we can learn a lot from our colleagues in the diversity and inclusion space. I do some work in this area, and the biology of feeling overwhelmed, right? The way that our brains respond and basically shut down our prefrontal cortex function is really profound. And so it's a really important process, or I think opportunity, to think about how do we support people in stepping into and leaning into that discomfort. Edmondo, I'm wondering if you have any thoughts about in your organization, how do we do this? How just as we need to meet patients where they are, I think we need to meet our colleagues where they are, but that's hard. So any examples or thoughts?
Yeah, so a couple thoughts on that, Michael. So thanks for teeing that up too. So one, I want to pull a theme I thought I heard from both Micky and Lisa, which I actually call consumerism. But stay with me here. So I'm not talking about buying your new pair of Nikes off the sneakers website. Like, no, I'm talking about, really a concept, really an acknowledgement that we're actually in a service industry. And actually, if you think about consumerism, you think about these components like convenience, access, transparency, price. When you address those, right, then you actually start to address these things like, let's give them choice. Let's actually ask what they're looking for. And then let's respond to that in ways that might be uncomfortable. Right? And so I like to think about some of these, I think about with the consumerism lens, and then compare them to other industries and say how might those industries have responded. But I'll tell you, so back to your other, your core question here as you teed it up, so we're an NCI designated comprehensive cancer center. We have, based on, NCI, rules and regulations and, and policies and so forth, we actually have a responsibility around addressing the needs of certain communities. And there's a little bit of funding around that as well, but we do focus on that. But I think one of the things that I think about from the digital perspective of that is I actually think that our provider side digital structure and org chart is wrong in most provider organizations. I actually think it's flipped upside down and it's slowing us down. So what do I mean by that? So I'm going to borrow, even though this is not what he was talking about, but I'm going to borrow a little Donna Bedian, right? Structure, process, outcomes. And so I'm going to borrow a little Donna Bedian from the, from the quality, and safety, kind of transformation work. And we haven't addressed structure around digital in the provider space. So what do I mean? So what you find in most organizations is that IT is in charge of digital. And IT is not a strategic organization. IT is what we call a KTLO, it's a keep the lights on organization. And we're trying to flex them into being a strategy organization. That's a mistake, people. That's a mistake. The overarching drive around how we build this and how we actually get uncomfortable with, addressing consumerism, things like that, you actually have to think about it from a digital perspective, and digital is your strategy. That drives what IT does. That drives how you think about data and data flows, and that drives how you innovate. Right? And so right now it's flipped. What you'll find is you have a lot of IT shops that have a tiny little digital component in there, kind of trying to survive, trying to grab some resources. Wrong way, right? You got to flip it. And so I think that if we actually do that, and then we bring the right competencies to that overall digital, umbrella, with, again, the core components of IT and then data and then thinking about innovation, that's actually how you execute on some of the things that we're talking about. Again, I'm thinking about it from a provider perspective, although it may apply to other settings.
No, I love that point because, right, there's so many layers to the complexity in setting up a health equity intention for success. And so Pooja, you and I spoke about some of these organizational structures. And so I wonder if you could illuminate some of the things that you've learned and, maybe perhaps things you would change as you look at specific solutions.
Yeah, Edmondo, I think that was it's a great point, and actually one big shift that we've made in the last year is we've created a digital committee that's member-facing work, and what we do is it's a pipeline committee, right? So you have CXCI people there, and the clinical people there, and quality people there, but also IT is there, so that they're in that conversation right from the very beginning, and they understand the utility of the tool and why we need it and what population we're trying to serve before they start getting in the way of like, well, we can't do that API or this or that, right? We have to have that conversation up front so that they're bought into the mission of what we're trying to accomplish before they're being asked to sort of, step up and do some work in that area. So I think that is really key, and hopefully that allows us to really take that work across the entire organization, so we're aligned in terms of what we can actually do for people. But, Lisa, I just wanted to also respond back to you. What you're saying is really important and very key, and it's often the missing piece. And I do feel like we end up hearing a lot about what people want through several filters. And that's the piece that's really missing from what we're able to do right now. And it's a good point that we need to build that in. So I appreciate that, that comment. I think the other thing that really comes up in terms of organizational structure that we're working on is really trying to get all of our data streams aligned so that we can get what we need to actually be able to leverage digital health for our membership, right? And so a lot of that is, do we have the SOGI data? Do we have the demographic data that's accurate that we can actually use? Because, there are a lot of limitations on how you can reach out to your Medicaid population with consents and all of that. How do we look at our data and align it with zip code and area and resources so that we're really leveraging our resources for where we need it the most in terms of providing support for people who need it the most. So I think the data infrastructure piece is a huge one, and we're getting better at it. I think as healthcare organizations, we now have the ability to cross-reference like EMR data, which again isn't perfect, but then you mix that with the data that we get and all these different lenses, and then you finally have something that maybe allows you to be able to really leverage digital technology for your membership. And the other thing that I think that we often forget that I would just put out there is once we have a tool available, how accessible is it really for our membership to us be able to get people on it, right? So we often pay for a tool, we think it's going to be really good, we have approval to use it in a Medicaid population, and then how do we actually get it out to our members in an equitable way, right? We're not just reaching the people who are reaching out to us, which is easy, and we do that, right? But we have to be able to think outside the box and be in the places where people are so that we're offering it to them where they are, and we're getting the people who are not as connected to the healthcare system the same access to tools that others have.
Well,
Michael, can I add a point? Can I add a point to what you're saying? And it's related to some of the learnings during the pandemic for me. I was practicing telemedicine and doing home visits. And I think we talk a lot about what these communities lack. And what we should do instead is flip that and say, well, how are they using tech? What do they want to text? And instead of saying, oh, well, there's no way to do this because we don't have a HIPAA secure server we can direct them to, and on and on and on, we should be asking ourselves, what are some ways for us to mitigate this? And during the pandemic, it's been easy. We've been able to text people, and we see that this is a very, very effective way to communicate with people and to have them communicate back. So this is also linked to the notion that everyone wants to use tech. We have this notion that Medicaid patients in particular can't do video visits because they don't have broadband. Well, I live in a neighborhood that has sketchy broadband, and it turns out all the patients I saw, they had a choice. They could do a video visit or just have a phone call. And 50% of them could do video, but a lot of them didn't want to. So it was their choice. They had personal reasons for not wanting to be on video. But I just offer this to challenge some of our assumptions about the population and flip the way transition the way we're thinking from, well, we can't do this because they don't have X. Can we instead say, well, even though they don't have this, they do have this resource or this asset. So how can we innovate and help using the resource they have?
Yeah. So can I jump on that point now? So because it's such a good point, and there's now increasingly research out there, and I think Mala actually did some of this research where, you know, it's not about whether or not people have access or even want to do it. It's about how you designed it. So the pushback I get a lot is, you know, we can't design, because we have a lot of Medicare patients. We can't design that. You know, my grandmother would never use, you know, a digital tool. Okay, maybe your grandmother wouldn't. Possible. Is your grandmother on Facebook? Because that's how she sees her grandkids, right? And so to me, right, you know, when my daughter was like, you know, 18 months, she knew how to flip through an iPhone like it was no thing. No one trained her how to do that. She just knew how to do that. So to me, part of what we have to think about is, are we designing it for the communities we're trying to reach? And we haven't spent the time to really do that well. And again, I think Ramala's team has done work on this. But if we go back to what Micky was talking about in terms of innovating in certain settings, I think some similar themes might apply. Where are we designing in the right settings to actually get engagement? Back to what Pooja was saying, you know, to get engagement with a particular population that we're aiming to get engaged with. Are we designing for them?
So Micky, I want to turn this to you because there are a couple of themes I want to lift up. So one is, how is the voice of the patient level, and how is that integrated, right, with design of solutions? And I wonder if you can talk to the integration of data as that too, because Pooja lifted up, right, that we have so much access, there's so much data out there, but it's often not at our fingertips. And so how do we bring together this idea of data and stakeholders and community lived experience?
Sure. So let me give like two thoughts on, you know, how we're sort of addressing that. One is that, you know, we, from ONC perspective, we don't have direct access to patients. We don't create technologies. We're all about the playing field, and we're all about making sure the playing field is accessible to all, and that is promoting accessibility to all. So one thing, and this is just building a little bit on Edmondo's point, which I think was just a fantastic point about the structure of how digital health is thought about in lots of organizations and lots of provider organizations, payer organizations, and others, which is either it's in the IT shop, sometimes it's in the marketing department. So, you know, you got those two things. And, you know, one of the things that we've been emphasizing, so just to level set everyone on you know, what ONC has done, we just promulgated rules, or rules just went into effect on April 5th, called the information blocking rules, which require that providers make information available to patients and to other authorized users. It also requires that they make that available via standards-based APIs. And the technical standards for that go into effect, you know, a little bit later. But the point is, it requires that they make it available via standards-based APIs so that a consumer, an individual, can download that information and have access to it on a device of their choice, for example. And so that's one way of trying to democratize this as much as possible, to be able to say everyone should have access to their own information, and every provider is required under information blocking to do this. And the definition of provider by that law is actually a pretty expansive definition. It includes LTPAC, it includes physical therapists, it includes laboratories, it includes pharmacies, It's very expansive, saying everyone needs to establish that as sort of the level playing field to make that data accessible. So that's, really an important point. And the second thing that I just want, again, just building on Edmondo's point, is that what I've been trying to emphasize as we think about this is, and as provider organizations think about this, because this is a pretty big change culturally and in mindset, and it really has to be imbued in the entire organization about this information sharing idea, which is that you share it unless you have a good reason not to, versus I'm only going to share it unless you give me 5 good reasons that I should share it, which is a little bit of the current mindset in lots of different places. And I've been trying to, sort of advocate for organizations to get beyond thinking about this as a compliance thing and more about thinking of it as a strategic thing. And I think that's a little bit consistent, or at least as I was interpreting Edmondo's comments, from an IT perspective or a compliance department, they're always going to think about the information sharing as a compliance thing, which is I do just what I need to do in order to be compliant. But how do we get people past that? And obviously, compliance is an important part of this, right? There are real civil and monetary penalties associated with violating, this law. So I'm not trying to pretend that that's not real. But how do you go beyond that to say this is a strategic opportunity? If people start to have the ability to have these kinds of applications in their hands, how do you now think about the whole population of my potential customers here as just having different attributes? It's not right or wrong. They just have different attributes, and I'm going to figure out what technologies are going to be the best way to serve them. And for some, it's going to be on the device. For others, it's going to be a phone call. Others are going to require a home visit. Others will be fine with a video visit, and trying to figure that out and then be able to say, I've got a whole spectrum approach here to meet everyone where they are, I think is an important part of the opportunity that we're trying to create.
Thank you. So part of the lens of this panel is to think beyond COVID. And so I'm wondering if anyone has any particular stories of what they learned through COVID, observed through COVID from a success standpoint and capacity building standpoint that you're really, really proud of or impressed by.
So, that last part, I wasn't going to go there, but I'll say, because but no, I will say one quick point, because I want to hear from the other panelists on this one as well, which is one thing that I think was reinforced for me with COVID as we kind of tried to figure out how do we get patients who are in active treatment for cancer, for example, and how do we navigate COVID in that setting? It was like this not easy thing, right? But one thing I learned is, so we had a 5,000% increase in our televisits in weeks, quite frankly. And then we moved everybody offsite who wasn't directly taking care of patients, and everybody worked from home. One thing I found, people are not afraid of change, right? We hear that all the time. Everyone's afraid of change. People are not afraid of change. People are afraid of loss, right? Because if someone dropped $1 million on your lap, you're like, that's a big change, but ain't nobody afraid of it, right? That's not the issue. People are afraid of loss. So what you actually have to navigate is people feeling that they're losing something as we change to, for example, pivot towards addressing a pandemic, right? And so that's one of the things I thought was really highlighted for me as we pivoted towards really taking care of the community in this setting.
Thank you, Lisa.
It's an interesting question. So 2 things come to mind. One related to just health equity overall, but one more specific. I mentioned the need for us to focus on digital literacy. And the example that comes to mind is and some of you who've heard me talk before may have heard this example, but it was a woman who I saw for shortness of breath. And I left a pulse oximeter with her and I showed her how to use it. But as I was leaving, I said, I would like for you to check this, every few hours and then text me the number you see on the screen. And she says, well, I can't send text messages right now because my phone is broken. And I said, well, what's wrong with your phone? And she said, I forgot my password. So we actually were able to send someone over to show her how to turn on her phone, how to change her password. And I think that is an illustration of why digital literacy or providing support to help people understand how to use that computer, because people forget a smartphone is a computer. So showing them how to use it and maximize it for health related reasons or interventions. But the second point related to this broader topic of health equity, and I'll use the word I've heard Adamika Arthur coin, the tequity. First of all, we need to make sure we all understand what we're talking about. Do we all agree on what this is and how we get there? How will we recognize it or know it when we've achieved it? And so I would, what I learned is that the thing that we don't seem to be talking a lot about is the need for these connections, these trusted messenger connections to help move people along these different continuums, not just during the pandemic, but I think if we find ways to connect folks with the right messengers to help them, these trusted messengers, we can get them to use their phone. We can introduce them and give them the confidence they need to use digital tools if they ever become widely available so people can access them.
That to me is that last point is one of the most powerful things that I've observed sort of during the pandemic is the power of trusted voices to engage and mobilize community. I've been blessed to be a part of a COVID task force that looked at supporting communities of color in San Francisco and the East Bay. And it has just blown my mind, the capacity and the power of those communities to really support themselves. And so it's a reminder that the equity piece is to enable people to support themselves, right, to make better choices. The last thing I want to lift up in our final minutes, right, is that this is a long game. All of us, right, in some ways we're preaching to each other. And I've seen, the other thing that I've seen over the last year is so many people burn themselves out because they don't manage their personal energy. So in a quick fashion, I want to hear from each of the panelists in terms of what are the things that you do for self-care that help you sustain yourself on this journey. And so maybe Pooja, we'll start with you.
Sure, thanks for the question. I think the thing that I have done that's a little different than I did before is give myself permission to rest a little bit. Sometimes in terms of when to engage and when to have those hard conversations and when not to. And so, I think if I've had a particularly hard set of time, especially in the equity work that I do, I give myself permission to step back for a week or two and just really take the time to reflect, because I think that reflection time is really critical. And it allows you to really figure out what you can do better next time, because I've been making mistakes, which I think is part of the work and how I know that I'm involved enough. And so I'm really taking the time to reflect and to rest.
Micky, what about you? Because you got a big job ahead of you.
Yeah, let's see, a few things. One is 2 days a week, we have my granddaughter here. So my wife and I both keep shifting off during the day, taking care of my granddaughter. Actually, right after this, I'm going to go spend 2 hours with her. So do that. Got a pandemic puppy. She forces you to think about other things and then running and yoga and try to balance all those things in between meetings.
I love it. Edmondo.
So mine's a little weird. So, and I push it so much better than me, because the reflection is really, really important. But I need to completely disconnect. And I can't completely disconnect unless I'm so focused on something else that it's not possible another thought comes into my head for that time. So what do? I actually drive, but I don't like post. I like drive on a racetrack. Right? And so when you're going that fast and it's that, and you got a turn coming, you're not thinking about all the stuff that's going on at work, who's texting you, what many emails, none of that's happening. It's like what's in front of you, hands on the wheels, what's the next curve, and whatever it is, to me, it's what gets you focused on something else that allows to. What happens is some of that reflection that Pooja talked about is happening in the background while I'm focused on something, while the frontal cortex is focused on something else.
Thank you. Lisa, bring us home.
So, I have started saying no. So as you might imagine, there's been a lot of focus on health disparities, health inequity, the need to lift up Black and brown leaders and communities. And we get overstretched because there aren't that many of us, relatively speaking. And so I find myself being overcommitted. So I've had to say no. I've also started taking some of my meetings off Zoom and take a walk, I'll take a walk. So walking meetings have really helped to get some fresh air. I get to move away from this computer. And I know a lot of people love this virtual and they're so happy we may never go back to it. I can't wait till I can see all of you in person again and shake your hand.
Thank you. Thank you. And I will end with deep, deep gratitude to all of our panelists for this wonderful conversation. For me, as you can tell from my background, I love the forest. And so I try to get into the forest at least 3 or 4 times a week because it's something about it just completely grounds me. So thank you, everyone, and to the audience for the wonderful questions, and hope we got to many of them. Thanks.
Thank you.